Yeah, thanks for having me. So yeah, I just background-wise, I work not only in a clinic here at Harborview, but I do work in the hospital on the consult service, and then I work in nursing homes too. So I kind of see the full spectrum of people with dementia from the very beginning and into the end. So well, some of this will be familiar to you, and some of it's maybe new. So yeah, my first slide. This is just, I think we're all kind of feeling this way, but this was just to kind of demonstrate how I can imagine people with dementia might feel right now with all the limitations and lack of things they can, you know, participate in and do, because I already feel that way, and if I had dementia, I can't imagine. So, and this gray slide is to, in honor of our smoke. I think we all feel like we're sort of, could we actually have one more thing in 2020 to deal with? Imagine you're caring for someone with dementia too, on top of everything else, especially those of you who are at home with small children and homeschooling too and working. It's just a lot. That's how I feel. Okay, so this was just a recent observational study that was published in Frontiers of Psychiatry in September, and it was a survey of people caring for dementia patients at home, pretty large number, and this is just to point out that when people had already had behavioral problems prior to the quarantine, that it definitely worsened things by quite a bit. So, and then people had new onset, whether that was because of progression of their dementia, but they just noticed that with the onset of quarantine, they had new onset of the behavioral and psychological symptoms of dementia. And those are some of the main ones they had. So these aren't violence and aggression, but they are things that can lead to violence and aggression. So they're just reasons, they're important to notice that people are seeing trends of increases in that, which I think we wouldn't all wonder about. And then people asked for medications to be modified in almost 30% of cases because it was so significant. Just a reminder that when people do something, it's usually to communicate something that they may have trouble putting into words. And so it's usually not meant to be personal, it's just they may not be able to communicate in another way, and that's particularly common in dementia. Aggression is really common, so it depends on how you define aggression and how long they're being studied. But about 5 to 10% of Alzheimer's patients, at least, exhibit violent behaviors when you follow them longitudinally. And then over a 10-year longitudinal study, 96% of dementia patients of all kinds developed aggression at some point. So it's very common. It's especially common in middle stages, at least for Alzheimer's disease and most dementias, but that's the one that tends to be referenced most often. It definitely increases caregiver burden and burnout in whatever setting that is, whether it's home or also in skilled nursing facilities or assisted living. And for those at home, it leads to long-term care placement. So it's an important thing if you're seeing patients in clinic or in a hospital to be thinking ahead about how that's going to go once they get home or whatever setting they're transitioning to. These are the most common things that are associated with aggression, not agitation per se, but aggression. So I started the psychosis because that's a particularly important one to notice in terms of violent behavior. So it's like when people are psychotic, meaning they have delusions about something or they're hallucinating, that can lead to more often to violent behavior rather than just agitation or maybe verbal aggression. So that one's should be notable, and that also has to do with the way we manage it sometimes. But aggression can go with all these other things as well. Patients will say when you ask why they might have had a behavior, if they're able to communicate that way, which usually means they're not in the late moderate stages of dementia, these are some of the things they talk about, which are not unlike, you know, the risk factors for aggression. But it tells you something about how we take care of people and what they're feeling. So a lot of the interventions that are non-pharmacologic are based on listening to this. So you can guess that even if they can't tell you, that if we know people who are able to tell you these things are happening to them, that people who can't tell you most likely have some of these things happening too. They just can't express it in a verbal way. They have to use behavior. So any chaotic or busy or noisy environment, when they're being asked to do things quickly, when things aren't simple, when they don't have any choice, if they feel like people aren't hearing them or interacting with them, sometimes boredom. Those are some things that patients tell us. When you have somebody who's having any kind of behavior, whether it's just, you know, restlessness or exit-seeking wandering, all the way up to violence, the first steps you're going to do are definitely medical evaluation. I know primary care doctors get tired of psychiatrists telling them that, but that's because it's really common. And having worked in a hospital pretty often, there's almost always a cause. It's sometimes hard to find, but probably the most common things are infection and medications. And especially with transitions in and out of different care settings, home to hospital, hospital to nursing home, there are a lot of medication errors that occur or changes. And so it's important to sort of think about that early, because if you can get rid of it or change it, then the behavior can go away quickly. We talk about this as delirium, but I think it's also true with demented patients who might not be able to tell what's going on. If they're in a setting where they don't have their glasses or they don't have their hearing aids, that's just going to make them more confused and not able to sort out, you know, what's happening in their environment. So I think it's really important not to forget that also when you're thinking about helping people. Behavioral history I'll get to in terms of what you try to ask about, and then what kind of non-pharmacological interventions are always recommended first, because they're less dangerous or less problematic in terms of side effects. This is just a behavioral dissection. It's sort of like being a detective. It's hard, I think, in the moment, especially with violence. You're not going to sit there and do this, but you do want to sort of do a look back for episodes of agitation when they're starting to happen more often. Can people start to identify patterns? And I tell families to start writing things down that they notice. And over time, you can sort of start to see a pattern. Was it always, you know, when a particular caregiver took care of them? Was it, you know, the daughter does fine, but the wife has problems, or vice versa? Was it a really busy day with like 3 appointments in a row? Or it was, you know, there was a lot going on in the family, like visitors were coming, or there was, you know, for a hospitalized patient or someone in the nursing home, did their roommate have a medical issue where there was a lot of activity around them, and could that impact them? And then obviously changes in things. Any change of setting or environment, even if it's just moving their Kleenex box from one side to the other, some things really matter to patients. So yeah, you know, it takes a while sometimes to figure out what it is, but these are the things we start to look at. And then things like just observing them, if you have time to do that and it's not an acute issue. Do you see them looking like they have pain, or they look like some, you know, they feel stressed or anxious? And then the person taking care of them, how are they feeling about interacting with this person? Are they feeling scared? Were they maybe frustrated or irritated based on other behavior or other things going on? And could that have triggered the patient? These are just things I think to think about as you're getting to know patients. And this, I would say, you know, common word is patient-centered or person-centered planning for dementia. And I think this goes into it in terms of knowing the background, because if you don't know they have these things, you don't think of them as potential ways of avoiding harm or avoiding violence, or intervening in a different way than you might have if you didn't know this history. And a really common one is trauma. So for example, when you're delivering pericare to a person that's had rape or some kind of a trauma history, it's good to know that, because they may react in a way that, especially if they have dementia, that you might not expect, but you don't know that history. So you might do things a little differently. Gun history is really important for people who are having agitation at whatever level. I think it's always good to know what's at home, because I think that's the most likely means to lethality for suicide, but also for violence towards other people. And hopefully in a nursing home setting or something like that, people won't have guns, but it's still worth asking. And then what else is going on in the patient's life? Have they had anything that looks psychotic going on from the caregiver, or you pick it up when you interview the patient? And then if you can, any psychiatric history. So say they have a long-term mental illness, but they got taken off all their medications in the hospital because they were sick, and nobody put them back, or they didn't know if they should put them back. It's good to know that, and I receive that a lot in the nursing home because, you know, people then start having their problems when they get there. So it's good to know those history facts. These are just some things that I think it's good to remind people that we work with to do. It's not always natural to do these things because I think people react when someone's very, very agitated or aggressive and do the opposite, which actually just worsens things. So instead of speeding up and, you know, rushing to do everything, it's actually better to slow down. And if you need to and no one's in danger, including the patient, it's good to just leave for a bit, just let things settle for a minute. Give them space, don't try to crowd them, don't try to force them to do things. Make sure you're talking to them. If they're not too aggressive, you can offer things like a distraction. Hey, look at this thing over here, or do you want a drink? Or these are common things that we would do for just regular agitation, not aggression per se, but they might be worth trying. But anything you do that is loud or busy or sudden is definitely going to increase the risk of them escalating. So it's just good reminders about what to do and what not to do. And then this is probably more for caregivers, but not necessarily. Anybody who takes care of someone, if they're telling you something that's not true, it's never going to work to argue about it or say that's not true, like a delusion. Like, you're having an affair. No, I'm not. It just makes them more agitated and upset. And or if you say you're not doing it right or you criticize them, that makes people angry and worsen in terms of their activity. If you react in a way that's defensive or take it personally what they're saying to you, then that can also make things worse, because then you start to react to them in a way that's negative or get, you know, criticizing. And so that it's important to, it's easier said than done to do, but if you can remember that, to say, okay, this is just behavior, it's not me necessarily, it can help. And try to remember not to be complicated in the way you talk to them, just using simple, very, very simple phrases, not to infantilize them, but just because it's too much to try to explain everything in great detail. If they're in a noisy environment or a place that's really busy, say you're out in a shopping mall, or you're in a day room at a nursing home, and that you notice that they're getting aggressive or agitated, if you can make them move or just say, hey, let's go take a walk around the unit, that sometimes is enough to quiet things down. And if it's in the middle of a care, I usually tell caregivers, if it's safe, then you can just walk away and come back and do it later. Don't try to keep doing it. You know, obviously, if you're in the middle of, I don't know, a wound change or something, you have to do parts of it to be safe, then do that. This is just things to remember for safety. If you're in a situation where you're the person that's being asked to help, doc, come on, you got to help us with this person that's aggressive. You know, making sure that other staff members or you are able to move people away. So especially in places where there's small children or people that are also frail and elderly, getting them away from the area if you can. Or alternatively, trying to get the other person to move, but sometimes that's harder. Seeing if there's anything you can look for around the patient that they could use as a weapon. And I'm not talking about guns, I'm talking like, you know, a stapler or something that you're gonna get in the head so that you can try to move them in a direction that's away from that. You know, I've had chairs thrown at me, all kinds of things. So you just have to think that way, and then you can try to be aware. Otherwise you get kind of caught off guard. Definitely try, you know, talking them down means sort of reassuring them, talking to them quietly, trying to make sure that they feel safe, trying to empathize with how they're feeling. Because usually if say they have a delusion, you may not agree with the delusion, but you can understand them being upset or worried about how they feel. And then if you can't distract them or those things aren't helping, you can try offering medication if you have it available. And, you know, sometimes that's not readily available. But if you have it, try it. And if you don't, then, and they're still aggressive, then if things are dangerous or out of control, then you should, you know, call the police or get other security involved if you're in a setting that you can get that. But the important point is not to be allowing yourself to be in danger. These are some things that increase the risk of danger, meaning violence. When people have a history of not necessarily actively using, but certainly if they are alcohol abuse or use any drug really. And as the cohort ages, I think there's going to be more and more of that other than alcohol. If they're actively psychotic, they're saying you're having an affair, you're cheating on me, you stole my things. That's going to increase it because a lot of times they believe it so strongly that you're not going to convince them otherwise. And in fact, one of the largest predictors of homicide is psychotic symptoms, and specifically Capgras syndrome, which is where you think your spouse is an imposter. So they might try to kill the imposter or the person they think that is your spouse. So that's an important one. And then if they're depressed and have psychosis as a part of that. Vascular dementia seems to have more propensity towards violence. I'm not sure exactly the mechanism of that, but that's in the literature. People who have a past history of just not tolerating things very well as a personality structure, or past history of maybe overreacting to things might have a more tendency towards violence. People who have been in first responder kind of situations, because not necessarily just PTSD possibility, but just they're trained to act in a certain way in what they perceive as a threat. And I've had patients, barricade themselves in, trying to protect people from a fire and all kinds of things like this, where, it's really hard to convince them because their job is to protect people and they think they are. So it's good to know who the person is that you're dealing with, because otherwise you just treat them like everybody else and you might miss an opportunity to change things. These are things that try to more preventative things than it is treating violence. Obviously, if we could have a consistent routine, that'd be great. I can tell you, every time we have a consistent routine right now in 2020, it seems like some other variable gets thrown at us. So, I mean, that's a nice ideal, but like even in the nursing home I work for, right now they can't all, and nobody can go outside because of the smoke. And that was a nice routine for a lot of people to get out of their rooms and have some space. And same with us, right? We can't go out anymore. But as much as possible, if you can keep things consistent. Things that are cluttered and really busy bother people a lot, so trying to keep things, calm down around you. Exercising or getting any kind of physical activity is really good for helping with structure. Making sure that people offer things often rather than having the patient have to act a certain way or ask for it, because a lot of patients with dementia don't have the language. So just, regular toileting schedule, offering them snacks or, water, even if they don't ask for it, is a good strategy, because then they don't have to act that way to get it. If you think they look like they're in pain, or that they haven't gone to the bathroom for a long time, constipation could be an issue, trying to address those earlier than later. And then just some other things that have shown some benefit, in studies. Sometimes certain smells, like if a certain person likes a certain kind of smell, it brings them happy memories, like lavender, maybe because their grandmother had it or something. But lavender and some other aromatherapy is pretty calming for a lot of people. Hand massage is another good one. If people tend to get upset at a certain time, maybe having a strategy where in the afternoon that you're having some of the things, maybe aromatherapy and massage. Pets can sometimes offer a distraction or help with loneliness to prevent people from needing to act out because they're bored. Music can also distract people, and there is some evidence for that in caregiving. So if you have to give a shower or you have to do changes of things and they like a particular kind of music, that can be really helpful. And then also familiar objects and pictures helps with distraction sometimes. So these are more like distraction than they are prevention per se. These are some of the medications that are used. I try to put them in order of, some evidence-based to like more dangerous and maybe not as effective. Acetylcholinesterase inhibitors, especially for certain kinds of dementia, are good first-line things to think of because they're a treatment for the dementia. People with Lewy body dementia, Parkinson's, sometimes they have a more robust response, and even for the neuropsychiatric symptoms, in my experience. Same with memantine for people in the moderate to late stages. Those are worth a try if you haven't, just to see if they make a difference. If you're trying to avoid things, especially that are you have black box warnings or limited in terms of side effects. Antidepressants, if there's an element of anxiety, or you think there might be depression, citalopram has good evidence in Alzheimer's disease for changes in behavior. It's a little problematic now because of dose limitations for the QTC interval. So you can't go above a certain amount, but sometimes you don't need to. And other antidepressants haven't really been studied that way for Alzheimer's specifically or other kinds of dementia, but they can also be effective, especially if there's either a background history or you think there's an element of depression. Addressing sleep-wake disturbance can be helpful. Melatonin for some people is helpful, especially if they're not getting daylight exposure. They have a history of PTSD. Prazosin can be really helpful for aggression, all nightmares, and that usually is pretty well tolerated. And that can be any kind of PTSD. I think we think of it most for veterans just because that's where it was studied, but any kind of trauma, really. Antipsychotics, especially if they're psychotic. So those do work. If they have an element of psychosis, really the most appropriate treatment is an antipsychotic. And yes, it's supposed to be time limited and the lowest effective dose, and you want to get them off as soon as possible. But for some people, they really need that, and that, especially for people that may become violent, I think that's really important to remember. Gabapentin can help with pain. It's not really so effective for aggression or violence in particular, but it's just something to keep in the background of things that might help with pain. Trazodone, if there's sleep disturbance, that can increase risk of falling, but sometimes that, if melatonin is not helping, trazodone can help. And then there is some evidence for carbamazepine for sexually disinhibited behaviors, and so it's kind of toxic, so a lot of people don't use that, but that's just something not to forget. Just other things to screen for, or if you're seeing people in the offices or you're taking care of caregivers too, that sometimes they don't talk about it. So I think it's a good thing for anticipatory guidance just to be asking about that. If you need to talk to them alone, that might be what you need to do. They often, especially in nursing home settings, caregivers might just say that's part of the job, but really it's not really okay to get hit all the time or, have people punching you or throwing things at you. But they often just accept that because they don't know that they can get help with that. And so asking whether you're a doctor that works at a nursing home and is checking in on your staff, or you have a patient that's a spouse or a child of a person with dementia, just being aware of that. Sometimes when people have, there's a dyad where the caregiver is frustrated and stressed out and burnt out, and so they're acting a certain way that drives the aggression of the other person. Sometimes there's violence towards them that's not explained, and then they react and can abuse the person or hurt them just because they're trying to protect themselves, or they're trying to, they're mad. And abuse is an important thing to look for. So if you see unexplained fractures or bruises or things like that, it's a good time to sort of do more investigation. But the best time is to try to catch it at the stage of agitation before it leads to full-on aggression. If we see anything like that, we are mandatory reporters for APS. And so we want to make sure that we're not forgetting that. And then also giving them information about supports, and then whether they need placement in a different setting. And these are just some common resources I give out to people, just ways to get services that they might not have. I love the Alzheimer's Association. I can't talk enough about that. There's just so much information on there for caregivers, for medical providers, some for patients. They have a 24-hour, helpline. They have things in all kinds of languages. It's just a fantastic organization, and you don't have to have Alzheimer's to use that. They have information on all kinds of different dementias. And then a lot of these other ones are just for help getting help at home, or maybe placement, or other, activities people could participate in once we're done with COVID. But that's, these are the kind of things I recommend usually. I probably went over my